So we are live in 3, 2, 1. We start. So we are.
Hello, good evening, everyone. It's a great pleasure to welcome you all for this live webinar and Women's Cancer Conclave, Building Upon Challenges with Innovations. It's a pleasure to welcome and invite Dr. Ghanshyam Vishwas, sir, although he doesn't need any introduction, but sir is Executive Director at Spurs Hospital and, of course, a visiting faculty at American Oncology Institute. So good evening, Dr. Ghanshyam, sir. It's a pleasure to welcome you, and we give the floor you to set the contacts and start the proceeding, please. So good evening and over to you, sir.
Thank you, Horizon. Thank you, AstraZeneca, for this opportunity. Now we know that, so on 8th of March, we are already celebrating this month, in fact, this week, as a International Women's celebration. So I think so breast cancer and ovarian cancer, these are areas we normally discuss. And so today the forum is all set for understanding the advancement in ovarian cancer, which has happened actually quite late. I'll show in my slide that so ovarian cancers till some time back, till bevacizumab, till PARP inhibitors. So I think there was not much happening after the taxanes combinations. So to set the ball rolling, so we'll understand with each of these our colleagues, so how things are fared in regards to an ovarian cancer, especially an advanced ovarian cancer, so which is going to come back each time. We don't know, so within 6 months or a year, but this is going to come back in most of the patients. And everybody who has been treating ovarian cancer knows that this is one disease where patients can go up to n number of therapies. Till some time back, we didn't have much option, but today, though the options moving from chemotherapy to targeted therapy now, PARP inhibitors, and probably we are looking in the future or peeking into the future of immunotherapy in such situations too. So today's first speaker will be Dr. Soumya Surat Panda. He's a professor of medical oncology from some hospital, which is a DM curriculum there. So he'll talk on bringing precision to medicine to newly diagnosed ovarian cancer. So how do you look on newly diagnosed ovarian cancer, so stage 3 or stage 4? So are you going to stop at chemotherapy and surgery, or at least for some patients, you are going to work up in a different way and give them an idea that there is something on the horizon? So if Soumya joined, so the Soumya floor is yours.
Yeah, thank you, Ghanshyam bhai. So can I request the team to share my slides? Or should I share the slides? I have the slides.
Sir, you can share your slides, sir.
Right. So can you see my slides?
Yes, sir. Please make it full screen, sir.
I'm not sure if full screen then that will move or not. I'm not sure.
Sir, you need to click on enable editing at the top.
Oh, I made it full screen now. Are you able to see the full screen, or it is still the?
It is still the same, sir. Not the full screen.
Okay. So we'll today discuss about the HRD, that is the new BRCA, bringing precision to medicine to newly diagnosed ovarian cancer. So the concept is that earlier we used a BRCA gene as a preventive aspect. So when we discussed the BRCA, I will say a decade back, we are discussing about the role of mastectomy or role of a risk reduction salpingo-oophorectomy and how to screen the family members. That was the BRCA a decade back. And then subsequently came that BRCA as a therapeutic aspect. And then we right now have moved to the homologous recombination deficiency, that is the HRD aspect. So the message is that the movement is from BRCA as a preventive aspect, then to BRCA as a therapeutic aspect, and then subsequently HRD is the new way to treat the ovarian cancer. So why it is so important? Because most of the patients with advanced ovarian cancer, they relapse following a first-line multimodal therapy. So it is a highly prevalent cancer, as we know that in 2018, something like more than 3 lakh patients were diagnosed, and 60% of them have advanced disease. So most of the patients that they land up in our clinic OPD, they are in an advanced stage. Not only in India, even in Western society, the same thing. It is an advanced disease. So when we treat them, the outcome is mostly dismal. If we use only a chemotherapy, then the 70% of the women they relapse within 3 years of the first line treatment, and the 5-year survival figure. If the patient asks us that what is the cure rate in advanced ovarian cancer, sometimes they ask us, then it is something like 30%. So it varies from 30 to 50, but mostly it is a 30%. So there was a significant need for better first line treatment to improve outcome for women with ovarian cancer. So only chemotherapy was having a dismal outcome. We have seen this graph multiple times, but however, this graph is very important. This shows that the platinum free interval is a very important concept in ovarian cancer. So when we give a first line chemotherapy plus minus bevacizumab maintenance, then we wait for the disease to come back. So once the disease comes back, your platinum free interval, that slowly and slowly it shrinks from the first line to second line to third line. It shrinks with time. And the second line chemotherapy, we give them a platinum compound plus minus again a bevacizumab, and third line again platinum, and then we shift a non-platinum chemotherapy bevacizumab like a lipodox or a gemcitabine plus minus bevacizumab, and ultimately the patient lands up in an ILS, and unfortunately they succumb. So once the disease relapses, it is largely incurable, and first line treatment for advanced ovarian cancer is the optimal setting to achieve a potential cure. So give your best drug in the first line itself. Don't wait it for the relapse. When it comes to the progress in the first line management of ovarian cancer, I'll be precise that 2003 it is paclitaxel platinum carboplatin. 2011 bevacizumab entered, that improves the maintenance compared to only chemotherapy. 2018 a landmark solo one showed that in BRCA mutated ovarian cancers, you give them olaparib, then the outcome is much better. This is a paradigm shift to first bevacizumab, then subsequently PARP inhibitor, that is olaparib, restricted to only BRCA mutated patients. And in 2019, the Paula-1 trial that showed that if patients not only BRCA, if the HRD score is high beyond a particular score, which I will be discussing subsequently, you add PARP inhibitor plus bevacizumab, that is olaparib plus bevacizumab, then you are getting a much better PFS. So this paradigm shift of bevacizumab, then olaparib in BRCA mutated, and then in HRD subset, that is the landmark in advanced ovarian cancer. So the failure of the cells to repair DNA. So DNA damage repairing pathways, that is very important to understand. So these are some basic concepts that whenever a DNA is damaged, so whatever be the trigger for the damage, radiation, chemotherapy, reactive oxygen species, so then the damage is repaired by single stranded break repair and a double stranded break repair. So in the single stranded break repair, it is a base excision repair pathway, and in a double stranded break repair, it is either of the homologous recombination or a non-homologous end joining. So I'll not discuss the other ways, or like you have got a microhomology mediated end joining. So mostly single stranded break repair is dependent on PARP1, and a double stranded break repair is dependent on a homologous recombination pathway. Out of them, BRCA1 is one. So HRD, that is approximately 50% of the high-grade epithelial ovarian cancer, they have got a homologous recombination deficiency. So in those ovarian cancer, in the high-grade epithelial ovarian cancer, out of 100 patients, 50 patients will have a homologous recombination deficiency. So that means they are not able to repair their double DNA damage pathway, double stranded DNA pathway, repair damage pathway. So out of them, we understand that BRCA1 a germline somatic, BRCA2 germline somatic, and some other genes like RAD gene and then RAD51C. So these are some other genes. So beyond BRCA, you have got other HRR genes which also are sensitive to a PARP inhibitor. So the PARP inhibition targets homologous recombination deficient cells by exploiting lethality. So normal cell, when we come to normal cell, you have got a homologous recombination as well as base excision repair pathway. So homologous is double stranded, base excision repair is a single stranded. So both pathways are essential for a cell survival, for the repair of the DNA damage. When it comes to homologous recombinant deficient cell like a ovarian cancer, in that HR pathway is damaged. So the cell is dependent on the single stranded or the base excision repair pathway. But if you give a PARP inhibitor, so in that the base excision repair pathway is defunct. So PARP inhibitor in a case of HR deficient cell like a epithelial ovarian cancer plus olaparib. So in that the cell is not able to repair by a double-stranded DNA repair pathway or a single-stranded DNA repair pathway. That is neither the homologous recombination nor the base excision repair pathway are working. So this is known as something synthetic lethality. So already a damaged double-stranded DNA pathway is there. You are also impairing the single-stranded DNA pathway. So both the pathways, repair pathways, are defunct, and the cell ultimately dies. So this is known as synthetic lethality. So how do we identify HRD? So either you can go for the cause of HRD, you can look at the genetic changes or the genomic changes which causes a defect in the HRR pathway, and look at what are the loss of the key HRR genes, and you go at the HRR gene mutation test or a BRCA gene mutation test. Or what you can do is that you can focus on the effect of HRD. So what is the result of this defect in the HRR pathway in the genome? You identify the consequences of HRD by looking for the pattern of genomic damage that is done by a genomic instability test or a loss of heterozygosity. These are the components LOH and telomeric allelic imbalance or a large scale straight transitions. So you have got, you can either look at the causes of the, suppose for example, a car accident is there. You can look at the, what are the causes, like a bad road or something related to the car or something related with the traffic signals. So there are multiple pathways. You have to identify the cause. They are very difficult. Or else you look at the damaged car and try to find out then you try to repair that. So that is very easy. So looking at the effect of the HRD. So that is the end result. So one is the cause and the other is the effect. So the effect is one which one has been standardized right now. HRD genomic instability testing has the potential to identify more women with the HRD test compared to only HRR gene panel. So if you go to the blood germline, so BRCA mutation 15%. If you send a tumor germline or somatic or say paraffin block, then it becomes 20%. If you look at the HRR gene mutation, it becomes 30%. And if you are looking at the HRD, then 50%. So you are expanding the PARP inhibitor benefit. So you are exposing more of the population of ovarian cancer to a good drug. So you can expand your therapeutic field. So that is what if you do a HRD test. Coming to the ESMO guidelines, they all recommend the HRD testing is it identifies the patients most likely to gain by the PARP inhibitor. So the first line, if you look at the platinum sensitive relapse and the first line maintenance, the evidence is strong enough. So HRD testing in newly diagnosed setting can establish the magnitude of benefit conferred by PARP inhibitor use in BRCA wild type high-grade serous ovarian cancer and identify the subgroup of BRCA wild type patients who are more likely to benefit from PARP inhibitor therapy. So very important is that you are not only the PARP inhibitor benefiting the BRCA mutated, but also the BRCA wild type. So you are identifying the subset of the patients who are BRCA wild type, but are still gaining a benefit from a PARP inhibitor. So what are the validated methods to identify the HRD? So your analysis performed on a DNA isolated from a formalin fixed paraffin embedded tumor tissue, that is a paraffin block, and you assess the two factors to determine the HRD status. So what is the tumor BRCA mutation? It is present or not, and the genomic instability by the three methods as I have told you: loss of heterozygosity, telomeric allelic imbalance, and large scale transitions. So what are the consideration for integration of first line PARP inhibitor in clinical practice? So how does it impact in clinical practice? So you look at the first step, BRCA mutated or wild type, HRD score is high or low. Second is that bevacizumab is indicated or contraindicated. If indicated, you give the bevacizumab, and if the patient is having a good response and it is a HRD positive, then you add on the bevacizumab plus olaparib. So this is the step 1 and step 2. Step 1 BRCA HRD, step 2 bevacizumab indication and contraindication. Step 3 is a platinum sensitivity beyond the HRD status. What is the toxicity? What is the clinical stage? So these are the other parameters that you have to take into account while deciding on the PARP inhibitor. Coming to olaparib maintenance treatment in newly diagnosed ovarian cancer. So this is Solo 1 trial. This is the first trial that was a BRCA mutated subset of population, advanced ovarian cancer, and the Paula 1 trial that took into account not only the BRCA mutant but also a HRD positive. So the expansion of the eligibility of the patients. So patients were also exposed to bevacizumab. I'll come in detail to the each of the trial. This is the SOLO-1 trial. The SOLO-1 trial, it was again a stage 3 and a stage 4 high-grade serous or endometrial ovarian cancer. Germline BRCA or somatic BRCA mutant was there, and patients were exposed after the completion of the treatment olaparib or a placebo. And the primary endpoint in this trial was investigated SSH PFS, and secondary endpoints was PFS2, OS, looking at the quality of life. So these were the other endpoints. So coming to the primary endpoint of SOLO-1, a PFS benefit. So the median PFS was 56 months versus 13.8 months with a hazard ratio of 0.33. So this much is the magnitude of benefit. So that is the reason that it is considered as a paradigm shift. So coming to the PFS2 and time to subsequent therapy. So both were increased, and the PFS2, the hazard ratio was 0.46, and time to second subsequent treatment is SR 0.46. So patients who were exposed to olaparib, not only that the PFS1 is benefited, again the benefit continues even after the patient has relapsed during the PFS2, and also the time to second subsequent therapy is prolonged. So what is the adverse event? The nausea and the fatigue, vomiting, anemia, diarrhea. So these are the common side effects of olaparib, but they are all manageable. Regarding MDS or AML, that was 1% at 5 years follow-up. However, since it is there, we have to keep in mind while putting the patients on olaparib. So treating a non-BRCA mutant, this is the PAOLA-1 trial, a very important trial, because your comparator arm was a standard of care. So that is paclitaxel plus carboplatin plus bevacizumab. The other arm was olaparib. So you have got an intervention arm of olaparib, the control arm of a placebo. Duration 2 years. So what was the primary endpoint? So the primary endpoint was a PFS and sensitivity analysis of a blinded committee. Secondary endpoints were PFS2 and time to first subsequent therapy and second subsequent therapy, OS, safety, and quality of life. However, in this slide, the most important point is that the patients that were chosen were based on the HRD status. So in the PAOLA-1, they took the HRD status, looked at the score, and then subsequently patients were randomized. So it not only included the patients who had a BRCA mutant, but also included a subset of patients who were BRCA wild type but had a high HRD score. So this is the representative of first line patient population. So these are the hallmarks of this trial. It represents the first line patient population, pre-specified biomarker assessment, as I told you about the HRD part, and patients were this is only phase 3 study of PARP inhibitor with an active standard of care comparator. So you had already a bevacizumab arm as a comparator arm. Now let's look at the results. So the results were hazard ratio is 0.59. So median PFS was 22.1 months versus 16.6 months. So patients gained another 7 months in such a dreaded disease. Regarding subset analysis, these are all pre-specified PFS. So all were in the favor of the olaparib plus bevacizumab arm. Coming to treating them, also what is the percentage? Around 48% of the patients were HRD positive.
Sorry for intervening. You have 3 minutes left to conclude.
Yeah, I'll be coming close. So coming to the non-BRCA mutant patients, if we look at the difference in median PFS, not only the tumor BRCA, but also the HRD and the patients who were wild type BRCA but HRD positive, they were also having a benefit. So this, so the drug, the median PFS, not only in the tumor BRCA but also in the non-tumor BRCA patients are having a benefit, and the hazard ratio is 0.43. So coming to the patients, non-BRCA mutant patients who were HRD wild type, means the HRD score was low, though the graph separated, but it was not statistically significant. So PFS2 benefit was seen across all the population HRD positive, that include the T-BRCA and excluding the T-BRCA, but HRD wild HRD score, high HRD score. So in both of them, the PFS2 was having a benefit, but HRD negative, the benefit was not much. So PFS in HRD, both PFS and PFS2. Coming to risk categorization, high risk, low risk. Despite that, the PFS was equally maintained. Stage 3 and stage 4, again, it was equally maintained. Delay in time to subsequent therapy, was again supported. The patients who were exposed to the olaparib plus bevacizumab arm, they had a significant delay in the time to a second subsequent therapy. So coming to the response rate, again the overall response rate was highest in patients who were BRCA mutated, but patients who were BRCA even wild type with a high HRD score, they also had a good response rates. Coming to the discontinuation rate due to the adverse event, the adverse event leading to treatment discontinuation was around 20% compared to 6% in the placebo arm. So most of the patients could continue the drug, and grade more than or equal to 3% the adverse events, it was 57% versus 51%. So the drug was well tolerated because the first line most of the patients are in a good shape. What are the common side effects in nausea, fatigue, and hypertension, anemia? Because it was combined with bevacizumab, some of the side effect of bevacizumab was also there. And as we know earlier, the nausea, fatigue, and they were attributed to olaparib drug. Coming to the MDS and new primary malignancies and ILD, again the numbers were not very high. It was 1.1 and 1.3%. And the quality of life, whether in this advanced setting we are able to maintain the quality of life, the answer was yes. The quality of life did not differ between the control arm and the interventional arm. What is the takeaway message? HRD scar should be done. It is a new BRCA test. It's the key biomarker for predicting PARP inhibitor response. Do not stop only at the only estimating the G-BRCA or a T-BRCA in the first line. So solo one that showed a 67% reduction in the risk of disease progression. Median PFS was 56 months and PFS at 5 years was 48% versus 21%. And Pala one definitely showed that you have to do a HRD. And beyond the T-BRCA and the G-BRCA, even in BRCA wild type with a high HRD score, they do benefit with this drug. With that, I conclude my talk. Thank you.
Thank you, Soumya. So we know that Kashmir files is on the news, no? So everybody in WhatsApp, everything. So we are discussing about ovarian case files. So we'll have three presenters. So first will be Dr. Chinmay Pani, medical oncologist from Apollo Bhubaneswar. And then we'll have another Apollo guy, a senior brother from Kolkata, Dr. Prabhajo Mahapatra. And then, so another from the same state, but located at PGI Chandigarh, will be Dr. Chandan Das. So over to Chinmay for the first case presentation.
Thank you very much, Ghanshyam Bhai, and thanks Astra for taking the initiation. So this is the first case. So a 30-year-old female, G0, came to the consultation for the persistent pelvic discomfort, early satiety and bloating for the 6th month. So there is no family history of ovarian cancer. On examination, there is an ascites and there is an abdominopelvic mass, and that mass was too big. So July 2019, the pelvic discomfort, early satiety and bloating, and Jan 2020, they went to the emergency, and probably they're in denial. That's the reason. That's the only reason I think they come to the emergency so late. And CA125 level was 2,681. And the transrectal ultrasound, then CT scan done, and imaging findings suggest an ovarian mass with malignant ascites. So upfrontly, they went for the surgery, cytotoxic surgery done, and it was a complete cytoreduction. A high-grade serous adenocarcinoma of the right ovary with a disease in the omentum, peritoneum, and the lymph node, stage 3C, and there is no residual disease, complete cytotoxic. And C120 level was 279. Sorry. So the point at this juncture is that so young age, 30-year-old, no family history, high-grade serous carcinoma, stage 3, complete surgical cytoreduction, maximal cytoreduction. So with the genetic testing, genetic testing not considered at diagnosis. So because of not considered, so what are the evidences to do that, whom to test for the BRCA mutant? With the family history taken an important parameter, age at diagnosis are the things that need to be considered. And we all know that both are the poor predictors, but what about the BRCA mutant? So if you see the family history status in the BRCA mutant ovarian cancer patients, 53% had a relevant family history and 47% had no family history. And when you saw the age at diagnosis, almost 29% of patients are less than 50. 50 to 59 are 39%, and more than 60 are 32%. So almost 71% of patients are diagnosed after the age of 50 years who are the BRCA mutant. BRCA mutation is seen. So up to 40% of BRCA mutations may be missed if testing only performed in women with a history of breast ovarian cancer. So irrespective of history, age, we need to do the testing. And these are the evidences that if you see the country-specific guideline in Australia, France, Germany, Italy, and Spain, and all the guidelines say that it should be done at the time of diagnosis. And this is one of the publications from seminars in oncology, the guidance statement on BRCA and BRCA2 testing to ovarian cancer patient. So they are telling that tumor testing for BRCA and BRCA2 should be undertaken in order that the result available when it is clinically relevant for the patient and should factor in the local turnaround time for the testing and potency need for the genetic counseling and associated for the waiting time and so forth and so on. So because you need to anticipate many more things, sending the testing, coming the report, discussing the patient, counseling the patient, because everything takes time and with relevant other considerations. So so now the patient started on March 2020. They started on Paclitaxel and Carbo, and July 2020, the BRCA1 genetic testing done on the blood sample, and that came as BRCA1 wild type. So only so question is that whether we should do the tumor BRCA testing or the blood BRCA testing. So 21.7% pathogenic or likely pathogenic mutations identified in the tumor only. And these alterations could not be pinpointed on if only a germline blood-based BRCA testing was performed. Dr. Sharma nicely told that there is an addition of the 7% additional diagnosis of the BRCA testing done when you add from the germline to the somatic. And the tumor BRCA test has a success rate of 99.1%, and the turnaround time is about the 17 calendar days. And the tumor BRCA test could be implemented in a molecular diagnosis setting that may guide the clinical management of patients with ovarian cancer. So, what is the germline mutation? Germline mutation, we have the parental gametes and the embryo, entire body carry the mutations, and offspring, half of the offspring of gametes carry the mutation. But in the somatic group, so you have the parental gametes, then embryo, then the mutation happen after the embryo level. So the mutation only in the affected area, and you have no gametes carry the mutation. So germline mutations are inherited, found in all cells. Somatic mutations is not inherited, found in the tumor cell. What should the sequencing? So sequencing of the BRCA. So because the germline BRCA mutations are present in all cells, tumor tests and blood tests can be used to detect them. And since the somatic mutations are present only in the tumor cell, they can be done through the tumor testing. But then why not the blood first or this first? So in a woman diagnosed with the ovarian cancer, any BRCA mutation present in the tumor cell, whether mutation is germline or mutation is somatic. So this is the tumor cell where both somatic and germline mutation coexist. And in the blood, only germline coexist. So tumor cell, if you will do, then that is the reason why we are getting additional 7.5% of the BRCA mutation positive when they're doing the tumor cell. When you're doing the tumor cell. So the germline testing, if the BRCA mutated in the blood, so then it is a germline BRCA origin. If the BRCA is not mutated and the cancer patient of somatic BRCA origin, then BRCA is detected, then also it's a BRCA mutated. So for the patient, so our focus is the cancer patient. Sorry. Okay. So in the September 2020, BRCA and BRCA2 genetic testing done on the tumor tissue, and they got the inheritance mutation was detected. So So what is the sequence? So germline negative, then tumor testing. So a woman who is found to be BRCA wild type on blood testing, who needs a subsequent tumor test to establish whether or not had the somatic BRCA mutations. But here you have done the tumor testing and it is positive, then you do the germline testing, and this has the implication for the relatives. So because for us, patient is important. So we need to do the tumor testing first, somatic testing first. So if it is positive, then do the germline testing to see the inheritance. So the beginning with the tumor test rather than the germline test has the following advantage. So it will be conclusive as to whether or not an individual is a BRCA mutation positive. A negative germline is inconclusive. So fewer patients will require the 2 rounds of BRCA testing, and that's why I already told. So this is the workflow. Non-mucinous of the non-borderline ovarian cancer diagnosis, do the tumor BRCA testing. Result available within 4 weeks. If the BRCA mutation is positive, do the POP therapy. If it is the VVS or the negative, then genetic counseling and germline BRCA testing need to be evaluated. So this is the ESMO recommendation on the predictive biomarker testing for the homologous recombination deficiency and pathway inhibitor benefit in the ovarian cancer. Already, someone has already showed this. What is the level of evidence? Germline, they have given level of evidence 1, tumor 1, clinical validity is good, utility in first line is good, and in the clinical utility of platinum sensitive worker. But when they have taken the somatic mutations and the non-BRCA HRR gene, so this is 2. Clinical benefit is marginal, and the HR genomics assay like JS and LOH. So the test level of evidence is 1, and the LOH level is 2. Clinical utility is good. So this is the data from the Paula study that the tumor BRCA mutation is seen in 29% patient of the HRD positive 48%, and the non-BRCA mutant, these are the HRD, almost in the 42. The value is more than 42. They are seen in the 19% of cases. I was searching for the ASCO literature data. What they're doing in USA. In USA, almost HRT testing is done by almost 80 registered laboratory, and almost 13 gene they are included except the BRCA1, and they are doing the testing and they're giving the value. So in HRD negative in the 34% and HRD unknown is in the 18% case. So HRD genomic instability testing identified 19% of patients of HRD positive, excluding the BRCA mutant, and 6.7% follower found to have non-BRCA HRD in the pre-defined panel of 13 genes. So we're analyzing this data. So how it helps? Already someone has told when you have how the synthetic lethality, when you have given the PARP inhibitor along with the blocking the HRD pathway, how it helps, and how the double standard DNA break could not damage with HRD deficiency could not happen, and how the cell death is accentuated. And these are the actionable mutations that are low frequency in hereditary ovarian cancer. The BRCA1 mutations there, the other HRR mutation, altered expression, and other unidentified. So instability is actually very, very high level of around 50% of genomic instability is actually said. So to take away, so that is the reason why the HRR is the new HRT, is the new BRCA. So that's the reason, and because it is this 50% are targetable, and we have the enough evidences which we discussed later on, and also some has very nicely written. So this is the thing how we can do. So test all ovarian cancer patients irrespective of the age and family history. Background testing and diagnosis allow clinician to make informed and timely clinical management decisions. Only tumor BRCA testing enable the detection of both germline and somatic. Pathogenic variant confers a definite increased risk of disease and have an implication for the treatment and prognosis. And HRD is present approximately 50% of high-grade ovarian cancer, and the tumor with the HRD are sensitive to PARP inhibitor. So now HRD is the new BRCA, so we need to do the HRD testing in the subsequent patients. Thank you.
Thank you, Chinmay. So we now move to the second case presentation, case discussion. So Dr. Prabhaja Mahapatra, the senior medical oncologist at Apollo, Kolkata. Welcome, big brother.
Thank you, Ghanshyam. Let me share the screen now.
So he'll discuss on treating recurrent ovarian cancer going beyond chemotherapy.
Hello. No. Ghanshyam, can you see my screen? Hello.
Yes, yes.
Hello. Can you shall I start, Ghanshyam?
Yeah, please go ahead.
Okay. Thank you, Dr. Ghanshyam, and is actually so close to me, and always remember being away from Orissa. Still, always remembers me in all his conferences, and I'm very grateful actually to Ghanshyam.
Sir,
And,
please make it full screen, sir.
Yeah.
So click on play icon.
Okay. So my talk is actually recurrent ovarian cancer. What is go beyond chemotherapy? What is this is actually not very case-based discussion, but a little bit case and discussion. And the slides were supplied by Astra. This is actually a female, 2017. Most likely, that time we are more of surgery and chemotherapy. She presented with the abdominal mass, adnexal mass actually. CA125 was high and CA was normal, and she underwent a laparotomy and cytoreductive surgery actually, and the diagnosis was high grade serous carcinoma, and it was 3C. The standard was actually chemotherapy 6 cycle paclitaxel carboplatin, series of paclitaxel carboplatin. And after actually as the 3C maximum the relapse, and she relapsed after 14 months, and that time actually she was again fit for secondary cytoreductive surgery, despite being some confusions actually. Maximum tell ki second cytoreductive surgery gives benefit to the patient, and she had a second cytoreductive surgery and have a chemoport insertion. And second line she received gemcitabine carboplatin. There may be a little bit confusion here. There are a lot of drugs what can use with or without bevacizumab, or but she received gemcitabine carboplatin. This is a hypothetical case. Again, she relapsed 8 months later, and she was still partial platinum sensitive, inoperable, and she received liposomal doxorubicin single agent. And maybe somebody was wanting to give platinum here also, but she had a 6-month relapse free interval, and after that she relapsed, and that time BRCA was done, and she received olaparib actually, and olaparib this is more likely as per the solo 3 trial, and she is doing well. So if you see the history of ovarian cancer, actually surgery or neoadjuvant chemotherapy surgery, and maximum they relapse, and you go on giving chemotherapy, and with all chemotherapy the progression-free survival will decrease, and slowly the patient have a disease which is not treatable or develop platinum resistant, and they die. Actually, what we exactly want any patient to be in the first line getting cured of the disease, or if it is not cured, more PFS, and so that we can treat them subsequently, and longer disease-free interval and longer survival actually. If somebody is not being treated in first line, any subsequent lines we need some drugs which will be increasing their progression-free survival. So if you see the different timelines actually, these are actually chemotherapy. There is no further chemotherapy. What we are using like paclitaxel, gemcitabine, liposomal doxorubicin, tipotican. But bevacizumab came at the beginning, and bevacizumab actually both as a first line or second line, or if any line if you are not using in the first line. Then the PrAP inhibitors came. Actually, it started with olaparib. Some patient we treated with capsule form of olaparib with study 19, and later on actually we got olaparib tablets, and then we have now rucaparib. Niraparib is with not us, and we have only theoretical discussions of niraparib. So if we see the indication actually, it is olaparib actually is a two first line indications, either with single agent as per SOLO-1 trial. SOLO-1 actually is a BRCA selected patient, either it is a germline or somatic BRCA, and not HRD or the all patients. And PAOLA-1, actually PAOLA-1 is the BRCA unselected, but it works in HRD positive. SOLO-1 is actually good risk patient. PAOLA-1 is usually more of a little bit high risk patients, but we don't know actually if it is olaparib is quite effective as a single agent in all the patient, or you need to add bevacizumab. But if you see the trial of PAOLA-1 and SOLO-1, bevacizumab, the hazard ratio is slightly better if you add bevacizumab. And so olaparib has two indications. We don't know, but this is only BRCA selected patient or HRD positive patients. If you are not using in the first line, you can use in the maintenance setting in SOLO-2 trial or study 19. They got an approval irrespective of BRCA in platinum sensitive patient as a maintenance, but the main trial is in actually for BRCA selected, or as per the fourth line and beyond as per SOLO-3 trial. Niraparib actually, it is actually first line primer trial. These are high risk patients, and they are BRCA unselected, and it got approved irrespective of BRCA. But if you see the benefit, actually it's more benefit in the BRCA or HRD positive patient, less benefit in other patient. But it's either it is benefiting as a agent in all patient, or the selection of HRD, there is some problems. Some patient, the selection process, the diagnosis process is something we are missing. Some patient who are actually responsive to PrAP inhibitors. So it's like second maintenance NOVA trial. It is actually irrespective of BRCA is a platinum sensitive, and fourth line and beyond as per quadra trials. Rucaparib is not approved as a first line, but what we understand, it must be effective in the first line, but it's not approved. So in the second line and beyond, it is approved, and you don't want actually to be BRCA. So the platinum sensitivity is the key. If somebody is a platinum sensitive, you can use. As you see the approval, actually rucaparib is not approved in the first line, and it's the relapse setting. Actually olaparib and niraparib is actually approved, and rucaparib is approved in the relapse setting. First line only niraparib and oraparib is effective. So if you see the trials, actually, these are all the trials of the PrAP inhibitors in the recurrent setting. Ariel 3 actually is the rucaparib trial. It's effective, more effective in BRCA and slightly less effective in HRD positive patient, but it's working in the platinum sensitive patients. Same is with niraparib actually. Solo 3 actually it is a BRCA selected patient. Solo 2 is a BRCA selected patient. But with the, if you see the study 19 phase 2 trial and some patients still who are BRCA negative, there is olaparib is still working. But the approval is actually within BRCA selected patient. And bevacizumab, if you see the bevacizumab trials, the benefit of PrAP inhibitors is more than bevacizumab. The same indications, but if somebody is actually require a PrAP inhibitors, to give PrAP inhibitors the priority, and bevacizumab keep for the future, because the benefit of PrAP inhibitors are more than bevacizumab. But if we are using, we have 3 PrAP inhibitors, whether it's same. If you see the trials, actually the hazard ratio is same. But if you see the safety part, if you compare with rucaparib with niraparib, only rucaparib actually there is more discontinuation. The safety parameters actually it's a grade 3 for side effects, treatment interruptions, or dose reduction. If you see the treatment interruption, more with rucaparib. But if you see the grade 3 for adverse effect and dose reduction, it's more with niraparib. But if you compare with olaparib and with either niraparib or rucaparib with the same safety main factors, that is treatment interruption, dose reduction, or grade 3 for ACE, so olaparib is much better. If you see the hazard ratio, with the same hazard ratio actually, if you see the hazard ratio of the trials of the recurrent ovarian cancer and where the olaparib, niraparib, or rucaparib has used as a maintenance, you have a equivalent hazard ratio. But if you see the safety analysis, you see olaparib is much better tolerated. Patient will adhere to the olaparib better and low discontinuation rate than the other drugs, niraparib or rucaparib. So these are actually the surveys actually, and how to see which are the better safety or adherence. So there is actually some persistent or adherence. Persistent is actually if somebody is taking a PrAP inhibitor for 90 days and the gap actually 6 months, and what is the gap of discontinuation. And adherence actually medicine possession ratio. If somebody, you give a patient a medicine for 6 months and see after 6 months how much medicine they have, this is adherence. If you see the persistent and adherence, actually olaparib is scoring more than rucaparib and niraparib. So what is our take-home message actually? Targeted therapy, actually we are using any ovarian cancer, we are tempted to use other PrAP inhibitors or bevacizumab. Right? They've changed how we treat ovarian cancer from chemotherapy to actually better quality of life and better survival maybe. But we don't have the survival analysis of maximum PrAP inhibitor trials. So, but it's not that all the PrAP inhibitors are same. They have a different, some are BRCA selected, some are HRD positive, some are actually maybe only platinum sensitive. They are all indication are not the same, but it's not that doesn't work in all the indications what other PrAP inhibitor works, because we don't have the trial or evidence to support that. And actually the pharmacodynamic and pharmacokinetics are different actually, and they have a unique toxicities actually. And we actually learned with using PrAP inhibitor the toxicities, and we know, and if you have the multiple options, we have to use the which is the best suitable or best tolerated with the patient with the equal effectiveness. Thank you.
Thank you, Dr. Mahapatra. So now we move to the third case file. So it will be dealt with Dr. Chandan Das. So he is the son of the soil like Dr. Mahapatra. So he is presently at PGI Chandigarh. So at least from different webinars, so I could understand that he has a lots of practical experience. And I will wish that during these non-COVID times, so I wish Dr. Mahapatra and Dr. Chandan to be physically present in Cuttack and Bhubaneswar when any physical meeting is there. So Dr. Chandan will talk
you.
about managing ovarian cancer patients on PARP therapy, PARP inhibitors.
Good evening, ladies and gentlemen. In the next 10 or 15 minutes, I'm going to summarize a case of ovarian cancer, which I treated and on treating also for the last 3 years. And I would say this case actually taught me a lot of things about PARP inhibitor, how to use, what are the toxicities, and the long-term monitoring of PARP inhibitors. So without any doubt, so we'll start. So this is a case of, sorry, it's a 2017. I saw the patient for the first time. So previously he was a case of PARP breast cancer, which is locally advanced, ER positive, PR negative, and HER2 negative. So initially she was treated with total mastectomy with the axillary clearance, followed by the standard adjuvant chemotherapy, radiotherapy, and also the tamoxifen. So she was apparently all right up to 2017, and she was started in 2016. So the date was slightly overlapped. In 16 January started with abdominal extension, vomiting. So on examination, there's a huge ascites. That was same thing was demonstrated by the CT scan. The ascites, omental deposit, adenoaxial mass, and there are few para-aortic lymph nodes. So there was a suspicion of the breast cancer, which is metastatic to everywhere. So the biopsy was suggestive of CK7, CK20 negative, WT1 positive, PAX8 positive, P53. So this is a classic high-grade serous ovarian cancer. And we did rule out it's not a CA breast by gross cystic disease fluid protein negative and mammoglobulin also negative. So there is no doubt it's a high-grade serous ovarian cancer, which is stage 3C. It is still inoperable because there is some deposit in the splenic hilum. So it was deemed unresectable at that point of time. And that point of time, it was thought of it might be due to a BRCA related case. So the test was available as BRCA PCR. So the PCR was attempted in 2016. It was negative. So please remember it was PCR. So she was given NACT for 3 cycles, followed by the IDS, the standard interval debulking surgery, which is TAH, BSO, it's the ICO, and followed by adjuvant therapy of 3 cycles of paclitaxel carboplatin. The CT was normal after that. The 125, CA125 was normal. So everything was fine. She was under follow-up. In 2018, she relapsed, which is, if you see, it's a platinum-sensitive relapse. And the site of relapse is peritoneal. So that time, the standard of care, I would say best available treatment was the gem carbobevacizumab, because in 2018 February, the PLD carbobevacizumab was not very standardized. It's still in the trial phase. So the gem carbobevacizumab was given, the 15 mg per kg bevacizumab. After 4 cycles, it was PR. We don't have any maintenance therapy in 2018, at least in India. So she was continuing further. The toxicity encountered in the peripheral neuropathy, thrombocytopenia, bevacizumab-induced hypotension, proteinuria. All are relatively well managed with a variety of measures. So the options here after 8 cycles was bevacizumab or the PARP inhibitor, the olaparib, tucaparib, or niraparib, which was not available to us at 2018, at the end of the 2018. So somehow she able to procure the olaparib capsule outside India. So if you see here, this is the, I would say probably this was my first olaparib patient. So they say September 2018. So I wrote the olaparib capsule. So previously it was in capsule versions, right? So I wrote the olaparib capsules. So if you remember, there are 16 capsules he has to take in a day, 8 in the morning, 8 in the evening. So nowadays we have the tablet version. Previously it was in capsule version. So olaparib was a emetic drug, so it's a moderate emetogenic drug. So I started with ondansetron. So around 10 days after the starting of olaparib therapy, so you were presented with a lot of nausea, vomiting, requiring IV fluids. I would say the IV fluids. So if you remember, if you go through the NCCN guideline, this is the for the oral anti-cancer agents, olaparib list, olaparib, niraparib, and rucaparib, both are listed as a moderate to high hematogenic drug. I means there are more than 30% frequency of MACs. So I encountered the same. I initially given him the same, the 5-ST3, MSET, palnosatran. I have to give the olanzapine injection, IM injection, so that the vomiting was reduced, and I could able to start the olaparib once again. So this was, I was using the olaparib for the first time, right? So somebody is vomiting with a oral tablet. I was really, really concerned. So what is going to happen? The oral tablets, is he going to take more or not? So somehow I would start the olaparib with once again the olanzapine intermittently. So if you see the toxicity or the vomiting rates of all the olaparib, rucaparib, or niraparib, it is in the range of 75%. So 75% of your patient is going to have some form of nausea, vomiting, right? And very rarely it's grade 3, grade 4. Obviously, in my case, it was actually grade 3 because I required IV fluid, obviously not hospitalization, but required few IV fluids to settle down. So it was after 10 days of therapy. So things are really fine after that. See, able to tolerate the olaparib oral capsules. So I show you the chart, right? I used to monitor the CBC every weekly because I must say this was my first olaparib case. So at the end of the day 30, she was having anemia, cytopenia. I checked for the iron profile. It was iron deficiency. I gave the iron carboxymaltose. She was vegetarian. I actually searched for the B12 folate. It was normal. So there is no point of giving B12 and folate. So if you see here, there are around 50% of cases of olaparib, niraparib, and rucaparib, they will experience anemia. And around 20% of cases are grade 3 and grade 4, means you need to give the transfusion support and drug reductions. The cytopenia was non-prevalent neutropenia, so it was resolved after the time. We actually withheld the therapy for a week, and it actually resolves. The anemia actually resolves with IV ferric carboxymaltose. I actually gave the EPO analog, the darbepoetin, but remember EPO analogs are actually resistant, I would say, refractory in PARP inhibitor induced anemia, because the PARP inhibitor mechanism basically it will make the red blood cells refractory to EPO. So don't use the darbepoetin or erythropoietin in case of the patient with PARP inhibitor induced anemia. So I did the wrong thing. So I read and I later corrected it. So this is the dose reduction guide for the PARP inhibitor. If you have started with olaparib, nowadays you are having the tablet versions. You have started with 600 milligram of olaparib a day. The next will be around 500. The next will be 200. So after 3 dose reduction, you have to discontinue. So similarly, rucaparib, we have the other PARP inhibitor 600, 500, and 400. Means 1200, 1000, and 800 is the reduction. So rucaparib has a further dose reduction of 600 also. So there is 4 drug reduction in rucaparib and 3 in the olaparib. One point to remember, if you have a renal failure, olaparib requires slightly dose reduction as compared to others. So this was the drug, the anemia, thrombocytopenia, neutropenia, all are managed by withholding drug and reducing the drug. In 90, so almost 3 months of, I would say, olaparib therapy, the CBC was returning to normal. There hardly any vomiting, but if you remember, the fatigue is still ongoing and some form of dyspepsia, and she is able to tolerate the drugs. Right? So I would say in 2016 we actually done the PCR for BRCA, because that time we don't have the facility for NGS. So we repeated the NGS just to look for the BRCA mutations if there is any mutations. So it turned out to be BRCA negative, but CHEK2 was positive. So if you remember, this is the flow for the CHEK2. CHEK2 has the least chance of causing, or the least frequency of causing the cancer, breast cancer, and ovarian cancer as compared to the BRCA. BRCA, the probability is around 60 to 80%. CHEK is around 20%. The non-carrier is around 10%. This is the graphical representation of risk of any cancers in the various mutagenic state. And CHEK is a homologous recombinant repair defect. So this is the picture. If you want to remember, it's okay. So around a year later, obviously after around March 2019, we have the tablet version of Olapari. We switched to the tablet version. There is hardly any difference. The same as previously. She was absolutely fine. It's the CT was complete remission. The CA125 normal. So it was year 2 or the day 720. So you're still having the macrocytic pictures. So if you see here, the MCV constantly rising. It's around 115, 120, 115. This is the, I would say, the highest MCV I had ever seen. So I thought it's most likely MDS, because MDS will be a macrocytic initially and followed by a lot of dysplasia. So I repeated the peripheral blood pictures. There is no dysplasia. Even I repeated the flow cytometry, just look for any MDS clones. And the pathologist or the hemat pathologist are very sure there is no MDS clones. And we repeated the fees also. There is no MDS clones. So the flow and fees actually done as per a small project. Actually, it's not a routine practice for every other Olapari patient to go to the flow and fees. So Olapari, Brucapari, Nirapari having a definite risk of MDS AML. So if you have a patient who is the cytopenia is persisting and you are treated with every possible way, anemia, iron, B12, folic, you should have a suspicion of AML. Most of the AMLs are therapy related and they are refractory to standard therapy. So recently we lost a patient with the same Olapari induced AML treated with azacitidine and venetoclax, and unfortunately she died of this AML rather than ovarian cancer. So be suspicious if you have a cytopenia which is not I would say refractory to any of the therapy. So this is the MDS and AML risk. So in the 1 month earlier, I saw the patient. So it's around 3.5 years since the start of Olapari. So 1, 3, 4, 5 is the day. And she was absolutely asymptomatic. MCV is still 120. Hemoglobin is perfectly normal. TLC, platelet, everything normal. CA125 also normal. There is a small paper. Those who are long-term responder of Olapari, mostly they are actually HRR mutation or BRCA mutations. Those who respond more than 3 years, if you see here, the orange line is the BRCA mutant groups. So this patient also similar kind of situation. So my few suggestions to use, or I would say increase adherence to Olapari, means use a good antiemetic. I know initial days are really crucial. Obviously, you have to check for the IV and oral iron profile before you start the therapy. So if you have the anemia, you can start with IV or oral iron. Erythropoietin stimulating agents are relatively refractory. Don't use it. Fatigue, I tend to use the caffeine paracetamol combinations. I think I salvage many of the patients with this combination, the crocin pain relief. One point to remember, the initial 2 months is crucial. So if you cross the initial 2 to 3 months, then everything will be settled. You will have a standard patient with a whatever may be the modified dose, but the initial 2 months is crucial. And definitely watch out for the pancytopenia. And my message for you with the PARP inhibitor is the true example of the so-called precision medical oncology. And it delays the ovarian cancer relapse settings. It's very ultimate efficacy and safety. Initial 2 to 3 months is the key to use the Olapari or any PARP inhibitor. And thank you for this. Thank you for pleasant listening.
So thank you, Dr. Chandan. So that was in one-liner, the good, bad, and ugly aspect of a PARP inhibitors, Olapari, and that's a learning. So when you have managed the whole show. So yeah, so definitely, so iron folic acid, I try to do in all my patients because I was a part of that trial. So we have enrolled 20 patients, and anemia is really a big problem. And we know that our part of the country, so iron deficiency anemia, if any, so that can be corrected. And B12 definitely can be corrected. So now you moved from individual talk to now we move to the panel discussion. So I'm going to moderate this. So we have a galaxy of panelists. So Dr. Prashant Parida from SCG and Regional Cancer Center, Dr. Sushant Paikrai from SCG, Dr. Jogmaya Patnaik from KIMS, Dr. Priya Naik from Some Ultimate, and Dr. Ganesh Sudhi, my colleague at Sparsh. So what I'll try to do is like So what are we going to do? Because since HRD is slowly, most of us are having an experience of doing an HRD. So how things are going to change in times to come. Hope my slides are visible. Aram?
Yes, sir. Yes, sir.
Yes, sir.
So optimizing outcomes for newly diagnosed ovarian cancer patients. So we'll not discuss about a recurrent setting or a second line setting or a third line setting. Absolutely. So we'll focus on the newly diagnosed ovarian cancer patients, because we know that this is the most difficult and the crux of the situation now. Probably things are getting more complicated here. So as I said, so my colleagues, so 5. So Dr. Amit could not join because of his mother illness, and he had to fly to Delhi. So we agreed that genetic mutation tests are getting, so for every patient that's become important. So some ground reality. So sometime back the cost mattered. So genetic testing, why you are going to do? So is it a blood versus a tissue? Is it an HRR versus HRD? And experience of HRD is probably at least once the like generic biologicals. So generic HRD is now available. Test support from companies and first-hand experience of using this drug in a first-line setting, newly diagnosed advanced ovarian cancer. So Prashant Parida, so just brief on each of these. So no descriptive, just touch upon these points so that we can have a fruitful discussion.
Yes, very definitely. Previously, cost was a very important factor for most of us, and now the cost has drastically reduced, and with support from the company side. I have in my clinical practice, I have started doing this BRCA1, BRCA2, especially in at the diagnosis of epithelial ovarian carcinoma. So that was a important factor. And genetic testing, yes. So previously I was doing only germline. So germline, as well as I've started doing tumor BRCA also. Blood versus tissue. So both are important. And experience on HRD, though I have started recently. So experience is very minimal, but that is a important scenario where we can start our PARP inhibitors, especially in maintenance therapy after response to first line platinum doublet. Then support, definitely it is a very important aspect, because due to support, most of our patients now able to do these tests. And first-hand experience, as already discussed extensively. So, especially I have the largest experience with olaparib, and initially few months with anemia, cytopenias, nausea, fatigue. So these are the common toxicities I have came across. So if we can manage the initial few months, 2 to 3 months, then those patients will do well in long run.
So thank you, Prashant. So Sushant, blood versus tissue, HRR versus HRD.
I will go with HRD and in tissue.
Okay.
If available.
So a little less than that, because even HRD, suppose.
We can go, nowadays, in every patient, I am able to send BRCA1, BRCA2 mutation in blood. Sometimes tissue is not available, but one patient also sent for BRCA for the BRCA testing in tissue, and that was came positive. And cost still a matter, because that patient not able to procure the PARP inhibitor because of cost, and now she is on bevacizumab maintenance after the paclitaxel bevacizumab.
Right.
Is the front line.
Jogmaya, so if suppose tissue is not available, so will you resort to blood germline BRCA or blood HRR?
I will go for a blood HRR, but in blood HRR there will be a less chance of missing the mutations. But if it is possible, then I will definitely also try to add a tissue HRR.
Any experience of HRD, new generic HRD, Jogmaya?
No, sir.
Okay. So Dr. Priya, so any experience of generic HRD? So from Strand, Core, Medgenome?
No, actually, I could not. I have counseled all of my patients, but nobody has yet done this test. I mean, they could not afford this. They did not do only because the patient who had come, many patient had some outside. The tissue diagnosis was done outside. They could not do get the. I could not get the tissue, and likewise, I could not do first when patient
So
was not
Priya,
available.
so since we are discussing on first line today, and this meeting is organized by AstraZeneca, and the AstraZeneca people are also here. So just to clarify, so in a first line setting, so if your patient looks like they can be a candidate for olaparib, so the test, 1 lakh rupees test can be done free from AstraZeneca. So you can have an experience, right?
Okay.
So any first hand experience of using olaparib in a first line setting?
Olaparib, no, sir. Not in a first line setting, but like patient who are receiving olaparib from outside have seen them, but not first hand experience.
Right. So now, so we have discussed BRCA, HRD, HRR, so significance. So Ganesh, so what do you suggest? So you will do an NGS or a Sanger sequencing or a RT-PCR?
You will do NGS, HRD, you will do.
Right. So whom to test? Age, family history, any particular histology?
Histology will do all high grade serous will do HRD or BRCA testing, and if there is first degree and secondary relative and all BRCA related diseases, cancers, prostate, pancreas, all breast, ovary, all these we can go ahead with.
So when to test? At diagnosis, at progression. So what do you think?
Best to die at the start of the diagnosis only. It will help to patient and also counsel patient any relative at the risk or not. And as there is a problem issue of tissue availability later, and nowadays there are support programs. Best to do at the diagnosis.
So what will be your sequence? So germline first, then somatic, or somatic first, then germline?
Somatic first, then germline, it will be better.
Right.
As there is.
So which group of patients do you prescribe BRCA testing and how often? So stage, age, type, and family. So this is the Indian paper. So everybody probably in these 2 years of COVID, so everybody of us has tried to portray. Even last week we had a similar meeting where Dr. Somio presented the some hospital data of 40 patients in ovarian cancer. So this was led by Dr. Sudhir Gupta, and so probably from north, south, east, west, everybody contributed to this paper. You can see almost 20% plus of BRCA positivity. So with each passing month, you can see the VUS is coming down. And if you compare with the papers from South India, then Strand, then North, even with the Australia, so we have around 20 to 30% of patients with a BRCA positive. And to surprise you that 67% of the patients, so 2/3 of them doesn't have a positive family history, what Ganesh was alluding to. So age less than 50 years, so you can see still around 20% plus of BRCA 1 and 2. So though BRCA 1 predominates, even in more than 50%. So here you can see, so young or the old, so both these groups, the mutations are important here. So if you look at the guidelines, ESMO, ASCO, Society of Gynecological Oncology, so be it an ovarian, be it a tubal, be it a peritoneal, so irrespective of age, irrespective of histology, irrespective of family history, so you need to check for BRCA. So the timing of BRCA, so Ganesh rightly said, so probably if you look at this paper, so what other speakers have already alluded to, so try to do a diagnosis. Now, so you know that so the generic HRD is there. We have support program for germline BRCA, somatic, HRR also. So So why not to test it from the beginning? So you know that, so you can plan your patients for a particular therapy and you can plan your maintenance. So can you pick up more BRCA mutations if tissues tested? So everybody of us agrees, at least for last 2 years of discussion. So you are going to add probably another 10% of mutations if you are doing a somatic rather than doing a germline. So whether to do a germline first or a somatic. So as Jogmaya rightly said and Ganesh rightly pointed out, so you're going to add another 10% if you do a somatic. So we are moving from germline BRCA to then BRCA1, BRCA2 on a tissue, then HRR and HRD. As you move up the ladder, so you knew that, so you are going to detect more genomic instability, which will probably help your patients to be a candidate for a PARP inhibitors. So since tumor BRCA testing identifies both somatic and germline mutations, so do you think testing tumor first for BRCA would be advantageous for treatment decisions? So yes, everybody also agreed. So Jogmaya, so what are the problems you face for doing a tissue-based HRR or HRD? So what is the most important part?
Getting the tissue, if we're getting the tissue, then probably this is easy. There is no problem. So mainly if we get the tissue, then with the coupon we can do the testing.
Right. So what are the challenges for not opting? So very few labs offering tumor BRCA testing initially, now not confident on tumor BRCA testing, test access, scientific evidence, test cost, test quality. So what is the other way forward? So this we have been discussing for. So now we have already zeroed down that. So what to test and what we are going to, how we are going to follow this. So general understanding. So we have niraparib, talazoparib, rucaparib, olaparib. So since we have now rucaparib and olaparib in hand, so let's limit our discussion to that. So Prashant, so now is suppose for a first line ovarian cancer. So do you have a place for rucaparib?
Actually, for the first line maintenance, rucaparib
yes, no.
No, rucaparib no.
Right. So at this moment we don't have a trial which can help us taking into consider rucaparib. So many of us might think that since rucaparib is available, cost is probably better than the olaparib. So let us do that. So no, so it is only in a recurrent ovarian setting or on a later line. So but not in the first line. So for first line, Sushant, so what are the options? So niraparib and olaparib, how do you choose?
I will go with olaparib since it is available and I have experience with olaparib. So my first preference for olaparib in first line.
Right, absolutely. So if you look at the key adverse effects of PARP inhibitors, so Dr. Priya, so what are the key adverse effects of a PARP inhibitor?
Sir, actually, like I have seen the follow-up patients. So mostly I found the patients who had the complaint of nausea and this anemia. Few of the patients had anemia. And the most common was fatigability.
Right. So I think if those who have heard about Dr. Chandan's presentation, so he has so nicely alluded to those things. So on the right-hand side of the box, if you see, there are typical side effects of the drugs of PARP inhibitors. So hypertension, niraparib, insomnia, again niraparib, raised liver enzymes are characteristic of rucaparib and niraparib, raised cholesterol, rucaparib. So a small fragment of MDS can happen with any of these PARP inhibitors. So to say, so olaparib doesn't have probably a typical or atypical side effect as compared to the other PARP inhibitors that are available. So what are the, so niraparib you can see, so these are not typical, but these are more common with the particular drug that has been mentioned here. So again, so we have discussed about the PARP inhibitor dosing. So as Chandan rightly said, so probably rucaparib is one drug where you can go up to a third dose reductions. So otherwise olaparib and niraparib, so we are going to stop post second dose reduction. So cancer ovary, again, so nicely dealt with somia. So or newly diagnosed ovarian cancer, so be it a platinum, be it a combination of bevacizumab, so we are not going to have a patient's life more than 18 months. And we know that more than 2/3 of these patients are going to relapse. So at 5 years, so not even 40% of the patients are going to survive. So there was a significant need for better frontline therapy to improve. So before 2014, so we can see, so all chemotherapy starting from alkylating agents, then platinum, and then the combinations. So you can see, so there was a full stop after 2005, after the PLD papers were out. So 2005, 2006, so GEM and PLD, so there was nothing much happened till some time back. So current practice in management of ovarian cancer, so everybody is of agrees. So chemotherapy, then those who can afford bevacizumab, you add on, and otherwise this patient goes on for some of the other chemotherapies till they have irinotecan, pemetrexed, the oral etoposide, so what not. So DRD in cancer ovary, so as again Somya rightly said, so 50%, 60% of these patients will have a DNA repair deficiency, so that makes these patients, ovarian cancer patients, a good target for these PARP inhibitors. So let us look at the wish card. So Jogmaya, so what is the wish card for a maintenance treatment in newly diagnosed ovarian cancer? So what are the possible maintenance in a newly diagnosed ovarian cancers?
Sir, as we have known from the previous discussions, we'll always it is always better to give maintenance after a first-line platinum-based chemotherapy regimen if the patient has achieved CR or at least a partial response. Maintenance can be two. Either it is in BRCA mutant patients, it is either PARP inhibitors like olaparib, or if bevacizumab has been used previously in the initial treatment, then bevacizumab and olaparib maintenance can be given.
So Ganesh, you want to add something to what Dr. Jogmaya said?
No, she rightly said. Mainly, actually, we have observation is the one of the method we actually practically using nowadays. As bevacizumab cost is little lower, so patient is affordable. We are able to be bevacizumab, and now there is data PARP inhibitor plus bev, so we are doing that.
Right. So as in a clinical practice, I think even today in 2022, even with the biosimilars or a generic bevacizumab available, so 2/3 of our patients will still be under observation, and they will wait for the recurrence and they will go for a second line. So definitely a quarter of patients will be a candidate for bevacizumab, and those who are a candidate for bevacizumab, they, if BRCA is positive, so they can be a candidate for olaparib or niraparib. So definitely rucaparib is not on the cards because so no first line data available, though the trial is ongoing. So somebody on a bevacizumab, they can be a candidate only for olaparib. So there is no data available for neither niraparib or rucaparib. So first line PARP inhibitors, olaparib or niraparib, so 2 years and 3 years or 3 years. If you are want to continue with bevacizumab, so the Paula trial, so that is only an olaparib. So no niraparib or rucaparib. So let me come to the first case. So is a 57-year female. So these are the cases where me and Ganesh have managed. So this is a 57-year female, definitely a postmenopausal lady. So came with a diagnosis of a high-grade serous bilobar metastasis. The liver functions were normal. So on a CT scan, ascitic, so needed quite frequent tapping, omental and peritoneal disease, baseline CA125 very high. A germline BRCA on a support program was done negative. So she had a low albumin. So that's why we started on weekly Paclitaxel and 3 weekly carbo, 3 cycles. Post 3 cycles means 9 doses. CA125 is almost 1/3. CT scan showed a good partial response. The liver metastases were gone, no ascites. The patients did not have any further tapping after initial few weeks. And at surgery, it was an R1 resection. So even at surgery, the liver was normal. So Prashant, so what is the adjuvant treatment, including maintenance, if any, or any additional test you want to do for this patient?
It looks like a high risk case because she's having R1 resection and HRD has not yet been done. So that I will do the HRD in this case.
Okay.
And for adjuvant therapy, if someone comes with HRD positive, then I have options of using maintenance PARP inhibitor, or if I will add bevacizumab, not in the fourth cycle, but fifth or sixth cycle, I can add bevacizumab because bevacizumab should be added after at least 6 weeks, 5 to 6 weeks after surgery. So same Pacli carbo plus bevacizumab from the fifth cycle, but if it is feasible and there is no contraindication for bevacizumab, I can add bevacizumab with Pacli carbo, and based upon the HRD positivity, then I can decide my maintenance therapy.
So Sushant, so Prashant said that we will do an HRD. Suppose this patient is not affording for an HRD, the patient probably can afford a bevacizumab with a support. So now, as Prashant rightly said, so initial 6 to 8 weeks we are going to avoid bevacizumab. So post that 6 to 8 weeks after the surgery, so whether you are going to add bevacizumab with weekly Pacli and a 3-weekly carbo. So Sushant.
I will go ahead with if patient status improve after initial weekly chemotherapy, then I will go ahead with the 3 weeks chemotherapy after surgery and with adding bevacizumab in adjuvant setting, followed by bevacizumab maintenance for 1 year.
Okay. So right. So probably you can take accept because since this patient was on a weekly Pacli and a carbo, so even the Japanese trial so did not show the survival advantage if you want to add bevacizumab to your weekly regimen. So now, so this patient, so this was the first case, so where I have sent an HRD. So thanks to Saibal, so who is organized today's meeting. So he actually gave so this was free from AstraZeneca as per their the free for those first liners. And these patients, and that was my first experience, and that too, it came as positive. You can see the report from Strand. So BRCA1/2 mutation status negative for deleterious or likely deleterious mutation. So this was the germline testing, but the genomic scar you can see 54.8 high. So HRD status is positive. So Priya, so now how do you plan? So for this patient?
Since this is like HRD positive, so now data are coming of like of adding olaparib with this maintenance bevacizumab. So after this completion of Pacli-Carb, I can go ahead with this olaparib and bevacizumab maintenance therapy.
So Ganesh, so you agree with Priya that you want to add olaparib with bevacizumab for this patient? So post Pacli-Carb?
Yes, of course, we can do that. If affording supportive program is there for Bev and olaparib, we can do that. But without bevacizumab also, you can give.
So Jogmaya, you want to correct it? Something you want to correct that?
For me, it will be a maintenance with bevacizumab and olaparib.
So Prashant?
Yes, if we'll see the trial data, the Paola data says if someone has taken at least 3 or more cycle of bevacizumab with chemotherapy, then only you can go with.
Absolutely. So I wanted to bring that point. If somebody has been exposed to bevacizumab in a Paola, then only you are adding bevacizumab. So this patient has neither received a bevacizumab in the neoadjuvant setting or later on, then these patients are only a candidate for olaparib. So you are not going to add bevacizumab in this case. So Priya, Ganesh, so you are not going to add bevacizumab. If the patient has been experienced with the bevacizumab with chemotherapy, then only, so the Paola, so new patients are not going to have olaparib with bevacizumab unless and until they have not been exposed. So this patient, Then we counsel them for olaparib, but this patient completed another 2 cycles of same regimen, and then they have lost to follow-up. But only this patient taught me that how HRD positivity looks like. So that was probably on last 1.5 months, 2 months, the patient has now followed up. Maybe because of the weekly regimen, the patient was getting quite a lot of toxicity, neurotoxicity. Second case is a 46-year female, nulliparous. It is a clear cell upfront surgery, stage 2B. So I can say this patient is a high profile patient, and she is a TCS, I can say TCS HR. So Sushant, so what will be your adjuvant treatment? Are you going to plan any maintenance? So money is not a problem here. So what is the adjuvant treatment, maintenance, if any, and are you going to consider HRD?
For this patient, I will go ahead with HRD, but it is clear cell variety is very difficult to manage, because whatever we given, it will relapse within short time. And my plan for this patient is
बात में देखेंगे. So we'll see the later on. So what are you going to do? So this patient is in front of you tomorrow morning. So what are you going to do?
That's why I tell you, because clear cell carcinoma is poor prognosis. That's why I will add in adjuvant setting also paclitaxel, carboplatin, and bevacizumab. After that, and definitely we'll go ahead with HRD status.
So Jogmaya?
I'll also go same with Sushant bhai.
So you are going to add bevacizumab for a stage 2B disease?
As an adjuvant therapy, I'll add bevacizumab because this is clear cell variety.
Priya?
So since this stage 2B, so I'll go with paclitaxel 3 weekly, 6 cycles.
What about HRD?
HRD status will be done, sir. Yeah, this tissue HRD status will be done.
So Prashant, so can you clarify the mess here?
So bhai, because looks like low risk group, so adding bevacizumab may not helpful much, and clear cell carcinoma prognosis is still poor, so we can reserve their bevacizumab for lateral line of therapy. So I'll go with the standard carbopacli with HRD and BRCA.
So Ganesh, hope you remember this patient. So what have you done here?
I don't remember, but weekly or 3 weekly chemotherapy will be sufficient.
So why weekly? 46 years, why weekly here? So weekly is only reserved for a poor performance status and low albumin. So this, we have done an HRD. So this was not a support, but these patients themselves, so HRD came negative. You can see a BRCA1, BRCA2 mutation is negative. Genomic scar score is 3.5 low. HRD status is negative. So these patients have been planned for a 3 weekly pacli and a carbo for 6 cycles. So this patient has completed 2 cycles. So friends, so we are not going to use bevacizumab, as Prashant rightly said. So stage 2B is not an indication for a bevacizumab. Neither a clear cell is an indication. So rather, we can reserve bevacizumab for a later lines of therapy, because this, as you rightly said, this patient is going to progress after some time. So bevacizumab have only showed some advantage only in a patients who have a repeated ascites, and that too in a stage 3C or a stage 4. Otherwise, early diseases have not shown any beneficial to a VEGF inhibitors. So case 3 is a 54-year female metastatic adenocarcinoma, stage 3C. So what is the plan for treatment? So Ganesh.
Stage 3C, we can, if there is support program or patient can afford, we will go ahead with 3 weekly paclicar plus bevacizumab.
So Priya?
Sir, metastasis, sir, this case are not clear, sir. So metastasis adenocarcinoma.
This was the biopsy report. So it was not mentioned high-grade serous, clear cell, mucinous. So this was a biopsy report from some ultimate.
Okay. Sir, I would go for CA 125. Then,
CA125 is 5.6.
Okay, sir. Then what as a stage 3C, sir? Is it an ovarian? Will it confirmed ovarian
This is ovarian.
malignancy?
This is ovarian. PET scan has been done in some ultimate only. So no diagnosis, no doubt in the diagnosis.
Okay, then I should go for BRCA testing and HRD testing. Then after
Right.
that, if it is like upfront operable, we will go for upfront surgery. Otherwise, I would go ahead with neoadjuvant chemotherapy for 3 cycles, then reassess.
So 3 cycles, including bevacizumab or without?
So without bevacizumab.
So Sushant,
No, if there is ascites and ascites, 3C means ascites with positive, then we have to give bevacizumab with paclitaxel carboplatin. And another thing, I support Dr. Priya that if it is upfront operable, we should go ahead with surgery. After that, adjuvant chemotherapy.
Jogmaya?
If ascites is there, then I'll go for neoadjuvant chemotherapy. Otherwise, primary cytoreduction followed by adjuvant chemotherapy.
So ascites is there, but it was not tappable. So need not have to remove the fluid. So he was not very much symptomatic for ascites.
Then primary cytoreduction can be done.
Right. So this patient again, so we have sent for HRD. So it has come negative. You can see a genomic score of low. So first one was positive, subsequent two are negative. So this patient, we have started on a 3-weekly paclicarbo, and she has just completed 2 cycles. Coming to case 4, so 45-year female, high-grade serous, stage 3A, upfront surgery. So adjuvant treatment, including maintenance, if any. So Priya.
Stage like upfront. Then I would say in this case I would go for paclicarb along with so this I think so BRCA1, BRCA2 testing should be done.
Okay.
HRD testing should be done. Then followed by this this maintenance with paclicarb, this adjuvant treatment with paclicarb along with bevacizumab. We can add adjuvant setting.
Okay. Prashant.
For 6 cycles.
Right. So this is like,
Yeah, Sushant.
I will give in this case the paclitaxel carboplatin, and if HRD positive, then olaparib maintenance for 2 years.
Yes, Prashant.
I'll test for HRD BRCA, and you have not mentioned whether any residual or not after surgery. If there will be residual, then I will add bevacizumab with standard paclicarbo. Otherwise, if optimal cytoreduction, then adding bevacizumab may not be helpful, even if it is stage 3. So that is the option, and based upon the HRD and BRCA test, then I will decide my maintenance therapy, whether I will go with bevacizumab plus olaparib, but if bevacizumab not added, only PARP inhibitor if BRCA or HRD is positive.
So I think so. Prashant has really touched upon an initial good point here. So this patient is from a judiciary system. So she is a advocate at Cuttack. So she had some menstrual abnormalities. She first lands up with a gynecologist, so they could see an ovarian mass. So initially that was not because CA120 was normal, so and everything, so there was shown an ovarian mass. So she underwent initial surgery with a gynecologist, not a gynec oncosurgeon. So a TLH and a BSO, so it came at malignancy. Then subsequently they went to Cuttack and got a complete surgery done with Dr. Sushil Giri. Post surgery, so according to Dr. Giri's note, so this patient has a complete cytoreduction, so no residual disease. Subsequent an ultrasound was done, no disease, right? So now Prashant, so would you advocate bevacizumab for this patient?
If there is no residual, then so looks like high grade possible means bevacizumab addition is the option, and it should be added from the second cycle onward. if someone there is no contraindication.
So this patient went on to Cuttack and received chemotherapy with one of our colleagues, 3 weekly Paclitaxel and carbo 6 cycles. So this patient was offered a PET CT scan done, so that showed a positive in a iliac node, so which was avid uptake. So Jogmaya, so what do you do now?
This PET CT was done just after chemotherapy completion or after?
So after 3-4 weeks of last cycle.
Okay. So what is the BRCA HRD status or BRCA status?
So you are interested in HRD now, right?
Yes.
Okay. So this was not asked by my colleague who was seeing there at Cuttack. So this patient was continuing with the Paclitaxel 6 cycles, and then the PET CT showed positive. So definitely, as a medical oncologist, you will ask for the block slides and everything, and you'll try to do an HRD, right?
Yes.
So Priya?
Yes, sir. Yes,
so
sir.
what are you going to do? Yeah.
Sir, I would go for definitely BRCA1, BRCA2 and HRD testing. Then if it is like positive, then I would go ahead with Olapari maintenance.
Okay.
And
if HRD is negative, then?
In this case, since it is a recurrent setting, so we would start we would go with bevacizumab, and I think it is platinum resistant. So
okay. So Ganesh,
This is
the patient has completed surgery. Patient has completed adjuvant chemotherapy. So PET CT is positive.
This is actually I'll think as this case is a platinum refractory, and PRPA inhibitor will not play any role. So we'll think about second line options.
So Prashant?
Yes, bhai. So looks like platinum refractory and relapsed. I presume that there was no node initially. So PET CT shows node means after 6 cycle of carbo.
So node was positive, Prashant. So it was a stage 3A.
No, bhai, initially before surgery.
So because the patient has undergone 2 surgeries in a day.
Okay,
so one initial surgery and then a completion surgery. So it was a stage 3A.
So if there is the only site of disease,
right?
If that node is the only site of disease, then possibility of doing a second loop surgery. So that is an option.
Absolutely. So I wanted to bring out that point. So probably, so if you are depending on a HRD, so if it is positive, definitely this patient will be a candidate for a PARP inhibitors. But so I think that probably this patient warrants a surgical opinion again. So we don't know, is this a positive report, because suddenly this PET has come positive. So initial 2 PET scan post in between treatment after surgery, it was negative. So now what happened? So since this patient was offered more cycles of similar regimen, so at Cuttack, so this patient was asked to complete another 3 cycles, so 9 cycles. And this patient had come to me post 7th cycle that he has lots of neuropathy. And then the whole story is cooked up. So I tried to collect the block. So I motivated them for HRD. And now what happened, you see? So sample rejection. So even after 2 surgeries, the block, you can see sample details. So the primary sample QC adequate. Quality analysis for FFP block ID adequate. So third point, you can see so the QC for the DIN value. So I don't know the full form of DIN. So here, so it is 1.9 for the patient, but which is required is more than 2.5. So she failed there. And that's why the block has come back. The money is yet to come back to the patient. So I don't know. So what to do? So I'm now in just a fix. So whether to go with Prashant's plan that we take a surgical opinion and go for surgery, or whether I go by Priya and Ganesh, so seems to be a platinum resistant disease. So probably look at bevacizumab and a second line therapy. So I don't know. So Jogmaya?
I think if PET is positive for a localized disease, surgical opinion will be better.
Right.
So by that we will get more tissue.
Absolutely. Sushant?
Actually, what is CA125 in this case? With the imaging, there is any message of
Normal.
CA125 is normal.
Starting may be normal.
Normal,
then
we definitely prove the disease. The only
CA125
test
is
it is
37. CA125 is
then
37.
we have to prove it is really a relapse.
Okay. So these are all slides, so I'm not going to discuss. So AE management strategies, I think, so Chandan has such a beautiful description. So take home, so probably we need to remember those. So this is a proposed algorithm. So let me conclude, is already 8:50. So on the left hand side, the 5-year survival as compared to many cancers, so ovarian cancers. So since there was a low focus, so low survival. But on the right hand side, if you see, so after probably ovarian cancer start getting funded, so there were so many plethoras of PARP inhibitors in place, combinations of PARP and bevacizumab, and now we look at some beautiful life advantage or a survival advantage with in this disease. So family history and genetic tests are integral part while dealing with an epithelial ovarian cancers, advanced and recurrent ovarian cancers. So for ladies and gentlemen, let us treat it as a marathon, not a sprint. So we need to judiciously use bevacizumab. So definitely try to avoid the drug in an early setting. We don't have much data available and neither it is beneficial. So keep it reserved for your later lines. So dilemmas, take help of tumor board, molecular board or other colleagues. So we have a WhatsApp group in Odisha among our oncology groups. So be it a medical oncology group or a Temple City Odisha oncology. So you can always take an opinion. PARP inhibitors are improving the outlook for the hard to treat cancers. So in tough terrains, so perseverance takes you further. And so probably there is a news coming up in China. The lockdown has started. So we don't know, are you going to or heading towards phase 4 or not? So thank you so much for your inputs and participation. So over to the AstraZeneca team for any comments, if any, and then the Horizon team.
Sir, thank you so very much on behalf of AstraZeneca. A word of thanks to all the faculties present here today evening and expressing their experience as well as their knowledge shared for the benefit of all. And I express a word of thanks for all the participants out here for being patient and listening. It was definitely the value addition in terms of the knowledge, sir. So thank you so very much. And you touched upon the HRD, sir, which is the talk of the town right now and has the potential to become HRD is the new BRCA. At AstraZeneca, we are always there for the patient support, sir, and everything is at your disposal. Please do reach out to us and give us an opportunity to benefit your patient in terms of the couponization which we have in place. So this is a submission to all the participants as well as faculties present here. So with this, sir, thank you so very much and have a pleasant evening, everyone.
Thank you, Devendra ji, and thank you, Horizon. Thank you, Saival. Good night.
Good night, sir. Thank you. Thank you for all your support and guidance, sir. And thank you to all faculties.
Thank you.
Thank you so very much, sir, for taking a lead here, and your direction, guidance was very, very important to drive this program. And see you in person soon, sir.
Bye.
Bye, sir. Good night.
Bye.